started.
Oh, maybe she's on mute.
Now jump in. Oh, hi. Sorry. Maybe I was mute before. This is Erica. I'm a project assistant based out in New York City, doing outreach at an organization here, but very excited to be helping with the learning community aspect of this grant.
Great. Okay, Elizabeth?
My name is Elizabeth Morrison, and I'm working with Mary and Erica for the learning community.
And then we go to our Blue Shield colleagues and have them introduce themselves.
Hi, this is Rachel Wick, Program Officer on the Healthcare and Coverage team here at Blue Shield.
Hi, also Carolina Gutierrez, Program Associate with Rachel.
Good morning, this is Apana, and I am the Program Assistant. Your technology person, hopefully. Yeah.
Great. Anything else on the Blue Shield team? We go quickly, and just so everybody can have a feel for who's on the call, and then we'll come back and start the content of the meeting. So I'm just going to name a geography, and if you're on from that geography, if you could introduce yourself. So how about anybody who's from the Merced Collaborative? Please introduce yourself. Merced.
Well, I know Kathleen's going to be on because I've already talked to her this morning.
Okay, so maybe they're not on yet. We'll do that part of the state.
Jennifer Brya. Good morning.
Hi, who was that? Hi.
Wayne Seguida from Los Angeles County Public Health.
A little louder.
Sure. Wayne Seguida with Los Angeles County Department of Public Health.
Okay, great. What about anybody on from Merced? Jennifer, was that you and Karen on behalf of Merced?
Karen Lincolns and Jennifer Brya. Yeah.
Okay. Okay. Anybody from Merced? All right. Joel, since you're on, we'll do San Luis Obispo, Transitions Mental Health.
This is Joel Derringer in San Luis Obispo, and I'm the project director for the Transitions Mental Health Association project.
Great. Anything else from your project on the call?
My name's Audrey. I'm Audrey Arco, and I'm assisting Joel on the project.
Great. Welcome.
Harry Johnson, a director here with Transitions Mental Health Association.
Great. Well,
this is Ann Robin, Behavioral Health Administrator for SLO County.
Great. Welcome. Let's move down the coast, down the state to Los Angeles. I heard one person from LA. Anybody else on from Los Angeles?
Hi, my name's Allison Clearfield. I'm a project manager with LA Care Health Plan.
Great. Is there anybody else from your team on the call?
Hello?
Yes.
Hi, my name is Hyun Wen. I'm the Manager of Strategic Initiatives for the Behavioral Health Department with LA Care Health Plan.
Great.
Hi, this is Marco Vasquez. I'm also a project coordinator with LA Care Health Plan.
Wonderful. And LA Care cohort partners?
Yeah, this is Joanne Priest. I'm with the Community Clinic Association. We're one of LA Care's partners.
Great. Welcome. Okay. Anybody else from the Los Angeles group? All right. How about from Hank?
This is Dorian Bradshaw from the Health Alliance in Northern California, and we're the lead agency for the Shasta Health Assessment Redesign Collaborative Initiative. And I have two other folks from our team on, I believe.
This is Melanie Ridley. I'm a consultant working on the project.
Anybody else from the Hank?
Yeah, Marta, I think she's on the webinar. I don't know if she's on the phone.
Okay.
On mute.
Marta, we see you. Okay. How about from Siskiyou?
Hi, this is Kathy Suvia. I'm the facilitator for the Siskiyou Community Services Council project, and I believe there are a few others on the line as well. And Marta and Melanie are also working with us on both county projects.
Right. I know you have some shared over.
Right. We share a lot of things up here.
Yes. Get sharing in the rural communities. Anybody else can do themselves from Siskiyou, please?
This is Paula Adams. I'm at Fairchild Medical Clinics in Wairika, California.
Great.
This is Sarah Collard. I'm the Director of Behavioral Health in Siskiyou County.
Great. Anybody? Okay, last but certainly not least, San Bernardino. Anybody from San Bernardino want to introduce themselves, please?
Good morning, everyone. This is Liz Villardo with the Community Clinic Association of San Bernardino County, and I'm project manager for the Integrated Safety Net Partnership.
Great, welcome. Anybody from San Bernardino?
This is Mark Simon. I'm a consultant and the facilitator for the project.
Great. And Jennifer?
Yes, we're.
They too are overlapping. They're not contiguous geographies by any stretch of the imagination, but in addition to working with Merced, you're also working with the San Bernardino Collaborative.
Right, so we just changed our hats.
Right. So what does a hat for San Bernardino look like as opposed to for Merced?
Well, I don't know. That's part of your cultural competence to figure out.
We'll have to let the communities define that.
Yeah.
Okay, great. Anybody else who did not get a chance to introduce themselves that's on the call? All right. So I'm going to go ahead and ask Rachel, take a little bit of a divergence from our agenda. Before we get into having each of you do in a brief round robin, sort of bringing us up to date on where you are with your projects on this particular task, I thought it would be helpful for Rachel to kind of remind us and walk us back through sort of where the foundation, sort of the genesis of the interest in this area and how this all is embedded within the work that she's doing there at the foundation. So Rachel, could you spend just a couple minutes in bringing us all, giving us your overview and thoughts on that?
Yes, well, good morning, everybody. I'm really excited to be part of our first call, and thank you to Mary and Elizabeth for leading us here. And I can't say enough about how lucky we are to have them on this project, so they're just fantastic. Like Mary said, I wanted to just set the stage for our call and conversation by going back to kind of the two important premises of this behavioral health initiative that the foundation is engaged in. And the first is that we think this work is unique and that we're focused on advancing integration at the systems level. And in order to do that, the second part of the premise is that this requires community collaboration among all the stakeholders in the community. Primary care providers, behavioral health providers, Medi-Cal, managed care plans, county agencies, and in some cases even hospitals have been a part of the conversation. And the goal really is that we need to break through the silos of our financing and care delivery systems in order to really develop to move integration and systems of care in the counties and to serve the patients that are eligible for the new benefit under ACA as well as those who have been served historically through the carve-out. When we met in due diligence and course of developing the grants, we heard directly from many of you that with all the change that was happening in the policy environment, that the first thing you needed to do was sort of revisit or conduct a new gap analysis has been kind of the short term that we've used for it. And when we thought about this work, there were really two issues. One is that there really is no tool that we were able to find that provides some template or guidance about how to do this at a system level. And as you know, we referenced the HRSA-SAMHSA tool and the 4-quadrant model, both of which we think are useful, but they're not going to get us to where we need to go to do this system-level work. The second thing is that we really didn't want to be prescriptive as the foundation. We could have sent someone out, to all of you and told you how to do this and given you the framework and all that, but we really didn't want to do that. And we wanted to sort of harness the leadership and expertise that you all bring in your local communities to sort of do this right. At the same time, I think there's an opportunity for us to create some shared frameworks or approaches, and that's really the purpose of this call today. And I'll walk through some of the elements that we think are really important that we do kind of in common. And how we get there is really, again, the purpose of this call today. The first is that we need to clearly define the patient populations and expected demand across the spectrum of need. And that's for those with mild, moderate, needs to those with serious mental illness. And only if we hold that whole population can we focus on the system. The second piece of it is we know many of you want to understand current system's capacity is to meet that need, and you know, understanding where you're currently at in your provider and county networks to deliver on the promise of the new benefit and the potential we have to deliver integrated care. We also see a couple of opportunities to stretch into new territory. And one is, we know historically the integration conversation, and currently too, is focused on clinical delivery partners. And I know you saw in our piece that we shared, we're interested in moving into the community and thinking about what the other resources are that are out there in the community, peer supports and other tools beyond sort of the four walls of the provider entities. And the second stretch area we think is around patient experience and preference. That there hasn't been, you know, a lot of, we've looked and we actually are going to use our Gary Langer survey of patients, low-income Californians, to get at some of this at a population level. But we think at your community level, it's critical to understand patient experience and preference, particularly given the diversity of California. And so we really want to encourage folks to look at those areas as well as part of this analysis. And in terms of the why around common approaches from the Foundation's perspective, the first is that other communities are looking to us to know how to do this. So in our initiative, we received 24 requests, and you know, folks on the call are part of the 10 that were funded. 14 didn't receive our funding and are really reaching out to us and asking that we share any resources we can with them so that they can keep moving forward on their work, even, you know, in spite of not having our grant money. So we would really like to share something back with the larger community about how do you go about doing this at the local level. And the second reason to kind of, you know, do some of this work in common is we want to tell a bigger story to inform state policy and practices. And so to the extent that we can roll up what these communities are doing to tell a bigger story to the state, I think that could be very powerful. And how can we use the gap analysis as a tool to tell our collective story? So I'll stop there, but today I just want to emphasize a dialogue. We are learning alongside all of you. We want to listen to where you're at in your thinking. I know people are at different places in terms of starting this work. We want to know where you're headed, how we can support you, and also how we can all really work together to build the field. And we think this is really on the front edges of the field in that sense. So with that, I'll get back to Mary and Elizabeth, but I want to thank you all again for being on the call. I'm really looking forward to the conversation.
Great, Ray. Thank you so much. I think that was really, really helpful, and I really, I want to really emphasize that I think what Rachel said is really important. In order to tell our story, you know, we really do have to have, I think, this common understanding and common. There are a lot of clarification around the language, so that when we understand what you're gapping, what you're analyzing, and what the Foundation is interested in, so we can make sure we're all speaking in the same language around that story, so that we can elevate it whenever appropriate. So that really is the purpose today, to just really try to understand back and forth what you are doing specifically, kind of address the issues that Rachel just talked about, and then see where we need to head in order to make sure that we're all on the same page on a lot of this. So what we thought we'd do now is to ask each of you to give us a brief update. We have set aside, you know, a large portion of the meeting to hear from each of you around the work you're doing. And if you look on the agenda that we sent you, which isn't up on the screen actually, we didn't redo the agenda for you, but on the agenda we asked you to think about as we go around the call here, to talk a little bit about, you know, share with your colleagues what the purpose, what the goal is of the gap assessment that you're doing. Most of you have the exact same deliverable around this actually within your grant. The language that the Foundation used is similar, if not exactly the same for each of you, although for LA Care, yours is slightly different, so you may want to speak a little bit about LA Care. But, you know, of course, it's nuanced by your own community, so we really want the group to understand what you're doing in your own neighborhood. We asked you to talk a little bit about the tools and the data sharing processes that you'll be using within your gap assessment process. And so in addition to the tools, we did share the one we received from San Bernardino Collaborative, so you all could see that, and the one that we got from the Hank, the Shark folks, and then we were also able to get the one that CPCA is using. And again, just so you can see what kinds of questions are being asked out there relative to helping to identify gaps. In some cases, I think there are some areas in there that we can build upon in this conversation today. In other areas, you're asking about different things. So, if doing companion pieces of work around your gap analysis, we want to hear about that too. So, for example, if you're doing focus groups, or if you are doing other internet research or data collection of a different sort, to please let us know about that. And then we definitely want to hear, what your struggles are, as well as what maybe some of your early successes are if you're, at that point. And I think, Rachel's information that she just gave us was really helpful. So if you have some thoughts as you're talking to us about what you're doing, of where you are collecting data that really aligns well with what she said, we want to highlight that too, and we'll have time to come back and talk some more about that. But you want to highlight that for the group as you go around too. And then we know that some of the completion dates were, some were now, some are at the end of this month to do this deliverable, and some of those probably we know are going to need to change and be extended. So we may want to get a snapshot from you too about sort of where you are in your overall process. Any questions about that? We head out to the geographies. All right, why don't we go ahead and start? I know, Doreen, you have to sign off soon, so why don't you kick off your collaborative and let them get started, and then when you finish, Hank, I'll ask somebody else to do this next.
And just to let you know, I was able to reschedule my appointment.
Oh, wonderful. Well,
so I'm going to be able to stay on. So, but as Mary said, I'm working with, my name's Doreen Bradshaw, and I have Marta McKenzie and Melanie Ridley, and that's our team is working on behalf of the Shasta Health Assessment Redesign Collaborative, and we've been doing some planning to prepare for healthcare reform, and that plan was kind of the basis of our grant proposal to the foundation. We are doing, for our project, using kind of a quicker gap analysis because in our project we also would like to do a pilot project that the committee agrees on, and using kind of the framework of the triple aim to monitor success or see some early kind of trends. This is a lot to do in 12 months, so that's why we're on kind of a fast track. We start our gap analysis, and I'll just talk about really quickly the process where we're at, and if Melanie and Marta want to jump in, they can do so. About, working, we have a pretty good committee that's working on this project. We looked at kind of, the committee met a couple of times, and it was very hard to kind of focus the group because Shasta is a very huge beast with, I would say, very diverse strategies on how integrated behavioral health is approached even within the community. So we decided we wanted to do some on-site assessments at the primary care centers, and so we took the CPCA survey and modified it just as an interview tool, but folks were very gracious, completed that ahead of time, and then Marta and myself, we actually completed 5 on-site interviews with 4 of the FQHCs who actually, if you're looking at where a lot of the primary care for Medi-Cal is being provided, especially with our new partnership codes, Medi-Cal Managed Care Program, 65% of the care for that population is provided for the FQHCs, so very important to look at them. And just so you guys understand, within the FQHCs, we have large, rural, frontier, then so just very different on even how they're approaching their integrated primary behavioral health. They're all doing various levels of it. We also have interviewed a private rural health clinic to get their perspective, and our plans are to include an Indian health clinic who has a very robust integrated primary behavioral health. So just, again, to get a spectrum of currently what does it look like and what's working now or not. So we're almost complete with that. And then quantitatively, we're doing fact sheets. We've been able to obtain some data from Shasta County Health and Human Service Agency that has pretty good epidemiology department, and, getting, SMI prevalence, emergency room, alcohol and drug need, psychiatric hospitalizations, as well as some other sources, I think, that were used from the 1115 waiver. We're also planning to, so we presented that last month. Next month, we're going to do aggregate community supports that are listed, available. We have a 211 up here, so we have a website that we can obtain some of that information, bring that back to the community or committee. And then we're also going to put all the clinic data that we have within HINC. We're going to look at doing some of the OSHPD data to patients and clinic, visits, and kind of the level of support beyond. We can see that for all those who report to OSHPD. So, Melanie or Marta, did you want to add anything?
Melanie, I think you covered most of it. We are, trying to identify those existing data sources that can really help us inform this needs assessment process. And so looking at where prevalence data is available, where utilization data is available, and then just trying to take that through the behavioral health subcommittee and trying to think through, what are those pathways to care, how do folks, where are they being served, and then trying to identify where those gaps are. Mm-hmm. So I think it's led to some conversation so far.
This is me. This was really helpful. Wanted to ask a couple quick clarifying questions and, invite the group to do that too, I think, and then we'll go on to the next partnership. But you mentioned that you, so how many surveys are you doing all in total? How many FQHCs? Is it 6? Did I count that right?
It's 4 FQHCs, 1 private rural health clinic, and an Indian health clinic. Okay. And are you doing other types of focus groups with community members or anything like that? We're not there yet.
Okay.
We did have that on our cut-in, but we felt we needed to get all this information first, right, so we could do a deep dive with the focus groups.
Mm-hmm. Great. Elizabeth or anybody else want to ask a question of Hank or other partners?
Well, not me. Thank you, Doreen. That was really helpful.
Rachel, I have a quick question about the substance use and behavioral health providers, or where are all of, is the SMI population being seen primarily in the FQHCs, or are you going to reach out to other providers in the community that might be serving that population? And I don't know if your networks are different or the same for the populations.
We're reaching out to others. We have folks sitting at the table. We're going to do some, we've talked about the county, about their org providers that they have. But, in the rural clinics, you could see outline areas, they are seeing a lot of the SMI because there's nowhere else to go. So that's the place. And then in, I'd say, urban dreading, the county does see some, but there's a lot also seen at Shasta Community, who's a major provider on the I-5 corridor. But then there's, still kind of, where do they fall? Because now we have, managed care and Beacon, and there's still some things to work out there as well.
Mm-hmm. So, Dan, your colleagues, do you see yourselves being able to generate, as I think Rachel highlighted when she was talking about the early points, some of this definitional issue about where people are falling relative to the mild, moderate SMI in terms of some of the data gathering and what the need might be versus got available, kind of. I mean, we can come back to it. I know this is a tricky part. But.
Yeah, it is a tricky part, and how it's funny, when we did the interview tool, we asked folks, to, kind of list a percentage of, their patients. It was all over the place, and Marta had the idea that, we actually interviewed folks within the community. We were there for 3.5 hours and interviewed different folks, like either administration or a primary care doc or urgent care. We're going to do psychiatrists, and we're getting at some different perceptions there too, which is very fascinating.
That is interesting. Yeah, I saw that you asked that in your tools, so maybe you could look at that and then look at some of this other epidemiology data you're getting has some information.
I don't know if you can correlate it. I don't think it's solid enough. A lot of it is, I don't say. Yeah.
Well, this is Melanie. I'll just add that, we're really struggling to find good utilization data. We have a lot of data coming from the county, and they're serving primarily the SMI population.
Right.
And so they've been really wonderful to work with and getting us some of that data. But then when you get to the mild and moderate, that's much more difficult to find utilization data than to map it against the need. So that's an area where we're really struggling.
That's a really good point.
This is Elizabeth. I appreciate the question, Mary, and hearing your team talk about this, because I think that this is a common problem, I think, for any county or collaborative, that SMI population is not defined by diagnosis, and so it's incredibly hard to get good evidence data. The key, of course, will always be doing functional assessments, and we'll be able to, we'll be able to get that from them, but it doesn't mean that they're seeing all the SMI population. So outside of what the county is seeing, I think it becomes incredibly hard.
Right. Well, and I guess another thing I would say, in our on-site interviews, we really learned that even how utilization is defining integrated their behavioral health programs and where they focus their efforts and how they configure their programs. And we only did, 5 so far, very different, very, very different.
Right.
So even where, they're located or not located, or, one organization is really, in a rural clinic who's been a leader is really more on the SMI, where, another rural clinic is more, all-encompassing of behaviors, they do a broader kind of spectrum of it. So it's very fascinating.
Yeah. You guys are getting good information. We sometimes joke about that the word integration does not in any way mean the same thing. Sometimes the words to each other, and we're not even defining it the same way. So to find out what
you're getting different, perception about what the prevalence and the need is from the different people you're interviewing in the clinic.
Looking at data, you can't really compare it because we don't have solid definitions. That people, we do, but people aren't utilizing them.
Right. Good. Any other comments for the Hank partnership?
This is Rachel. I have a quick question about just kind of where things are at with partnership and Beacon, and if in some of this analysis you're looking at, where's the conversation at around definitions between plan and county folks or in your community, and how those populations are defined?
We've had tons of trainings. We work with them. They're part of this project. Margaret Kislyak, the executive director of the regional office.
Do you want me to answer some of that, Doreen? Sorry.
Oh, are you on?
Margaret, no, I got on late. I just
Great.
I agree with what Doreen just said. It was ongoing. It was a conversation that started before we really rolled out the benefit, and so far there have been no disputes over folks that have been referred to the county or vice versa.
That's great.
So it's basically populations defined by a screening tool, because as you mentioned, there's no easy way to define SMI without doing some sort of assessment. So far it's going how well can be expected in the sense that it's never going to be a clear line.
Yeah, and the one thing is nobody's really utilizing expert yet.
Really?
Yeah, and they need more information, just like how do you define the success of utilizing that. And I think we found in our, on-site clinic, I think one clinic had done one or something. They're just not there yet. And then I think there's a blend of the staying healthy assessment tool. So there's some more work that needs to be done there to streamline that.
Right. One segue into SISCIU, since you're some overlap there anyway, and we'll hear how you're coming along, and then we'll proceed downward down the state. That was really great. Thank you. So, hi, SISCIU.
Hi, this is Kathy, and I'm from SISCIU, not SISCIU.
Sorry.
Wanted to get everyone clear on that. We are really, well, let me back up and tell you that our group, our partnership working on this project is representative, I think, of all of the providers and players who might be involved in integration as we move forward with this. We have the Community Services Council, which represents the family resource centers based in all of our 10 of our smaller communities in the county, as well as several of the other county agencies. We have independent social service organizations, nonprofits. We have FQHCs. We have hospital clinics. We have County Behavioral Health Department. Margaret from Partnership Health Plan, our COES program, is involved. And so it's a pretty diverse group involved on our steer committee. And then we have a variety of other folks on the periphery of that who are interested in watching what we're doing. We're really looking at defining the patient population. I mean, I'm hearing these common threads come out from some of the others, and trying to identify what the expected demand is. It's very challenging to define something that hasn't yet been defined, and so we're moving forward with that and hope to do a complete mapping of the assets and the gaps and what all the various ways of delivering service with our county. So our focus right now is on the development of a tool that will give us the information that we need to start working with. And Marta has been very, very much involved with us to do that. The other thing that we're working on a lot, and one of our objectives was to create learning opportunities within our county, within the various provider groups and others in the county, so that there's a more common understanding of what services are available, and even to the point that was made earlier, what does the terminology mean to various partners, and sort of defining within our group. So to that end, we're creating a resource, master resource file for all of our members, so that we'll all have the same basis of information and knowledge to work from, helping our group with that. So those are the two priority areas that we're working on right now, and I guess I'll let the others speak up. Marta, if you want to speak more specifically about the assessment tool, where we are with that, and then we've got several of our other provider partners on the phone as well.
Elizabeth, I have a quick question maybe you or your partners could answer. I was curious about what you're feeling like your sources will be for your prevalence data, whether that's for addictions or mental health. What are you looking at for sources for that?
This is me, Kathy. I can jump in. One of the key sources that we're using on prevalence data is the state-conducted behavioral health needs assessment as part of the 1115 waiver renewal.
Right.
And so they estimated prevalence rates for SMI population, broader mental health needs, and substance use diagnoses. And so that's primarily the prevalence data that we're looking at right now, because it is available by county. And just looking at local sources as much as we can for information on the needs that providers are seeing. But in terms of the most readily available data, that's really what we've been looking at.
Great, thank you.
Okay. Yeah. How accurate they were. Yeah. Marta, do you want add some additional information around the tool? Are you on mute or are you not there?
You're Marta, right, not Margaret?
It sounded like you invited Marta to say some more.
Yes.
So I was waiting to see who was available. If not, anybody else from the partnership, feel free.
This is Melanie. I'll just jump in again, and I've been working with Marta. We're just at the beginnings of designing a tool, so definitely interested in hearing today about what other folks are doing. As we said, we're working very collaboratively between the SHARC committee and the SISCU project, so we'll be sharing those learnings back and forth on conducting the needs assessment.
Okay. So you're developing your own unique tool, then, it sounds like.
Probably a modification of some of the other tools that are available.
Right.
This is Kathy again. I might add that our steering committee is meeting tomorrow morning, and we are planning in our discussion tomorrow morning to take the information that comes from this call today and some of the simulations and information that our members gather from this discussion today and build on that tomorrow and get much closer to finalizing our assessment tool.
Great, good. I'm glad the timing worked on this.
It worked very well. Thank you.
This is Rachel. It looks like Marta might be having some technical difficulties. So she's on, but she's having trouble contributing. I wanted to let people know.
Okay, thank you. All right. We can come back to you, Marta. No worries. Any questions then for anybody from this collaborative, and we'll move on. Very helpful. Thank you so much. Why don't we go to you, Joel, in San Luis Obispo, and Karen and Jennifer, I'll have you do Merced and San Bernardino last. So we'll do transitions, and then we'll go to LA, and then we'll do the Merced and San Bernardino.
Okay, so good morning. This is Joel Derringer in San Luis Obispo. We pronounce the S. We're a bit behind on sort of getting everything together here, but we did actually meet this week and come up with some sort of direct outline of what a gap analysis would look like. Part of it is just finding some of the general prevalence data, and I completed a report from Merced County, which pulled some down from the policy initiative. So we'll the public health demand data, but then we'll also get some of the clinical data. And we have on board, we have the benefit in our county is we have one health plan, one health plan. We're a county-operated health system. We have one FQHC network. We have hospital networks, and one county provider. So they're all part of the project. So rather than doing sort of, questionnaires, we're looking much more at doing sort of just key informant interviews, trying to gather the specific data that we're looking for. One thing in looking at demand and supply is how do you then gear it towards integration? Because at times, we're looking at, okay, we can identify how many physicians there are, we can identify how many, behavioral health providers there are, both on the mental health and the substance use disorder side. But what we're really interested in is sort of moving beyond that to just capacity to integrate. So it's going to be a large part of, I think, the sitting down and talking through with the principals who are all gathered around. The other piece we have to get, part of the proposal that we submitted that was funded is to do some patient surveying, and whether that's actual, and we haven't mapped out what that will look like, whether it's actually saying individual interviews or perhaps even focus groups with consumers of the system to find out what their perceptions are. And then the last piece in this is, as you were suggesting in your framework, is the community support being sort of the professional, whether it's psychology, mental health, or physical, medical, the additional community support. we also trying to inventory that.
So, Joel, this is Elizabeth. When you were talking about you all are distinct in the way of having sort of the one health and the one FQHC system, and I do think there's something great about that simplicity. For prevalence data, then you're utilizing the health plans data?
I think there are several sources. One is to look at the health plan, but that would be pretty new since they haven't done it much. It's only since the beginning of the year that they've contracted out or that they've been responsible for the broad range. No, I think there's sort of population demand data. It might be 20.2% of adults have a mild to moderate mental health need. But it's also looking more at some of the clinical data, going with the FQHC and seeing we've been doing mental health services for quite a while and seeing actually what their utilization is. One piece we are missing, is actually, and we don't really have a functioning medical society. We have no sort of representative group on the medical system to really even to a discussion. But we'll try and figure out, because there's so much that happens on the private side. We're very on the public side, and we're very good on the nonprofit side. But we don't really have any sort of organized private side to bring into the discussion.
You mean primary care practitioners out in the community?
Right.
Yeah.
Right.
So sort of like San Bernardino has that issue too, I know.
The utilization data, by talking to providers, that's a hard one to get prevalence data from. Utilization wouldn't be the same as, it may be a very inaccurate estimate of prevalence.
Right. With a local survey that's done either 2 or 3 years, and there are some mental health questions on it, but, it's pretty broad.
Mm-hmm.
Yeah.
Any questions for Joel and his colleagues or anybody else on your call that wants to add comments? I know you have a couple members from your team there. Let's move on then. Let's hear from the Los Angeles group.
Hey, Mary, sorry, this is Anna. I just want to test something just for 1 minute. I'm trying to get Marta back on the audio portion. Marta, if you can hear me, can you go ahead and try to speak, please?
Sure. Marta.
I see her on, and she's still having technical difficulties. Okay, I'm sorry. Go ahead.
All right. Well, when she's available, maybe she can chat to you and keep us posted, because or just start speaking, Marta, when you can get in, so we can hear from you. Let's go ahead and move down to Los Angeles and hear how it's rolling out in LA.
Hi, this is Allison Clarfeld. I can start off for the group because I know we've got a bunch of us on the call. Just a little bit of background about our project. So I'm from LA Care, and then we're partnering with our county mental health agency, DMH, our substance use disorder service provider agency, Department of Public Health, that's split up in LA County. And then on the primary care side, we have the county hospital and clinic system, Department of Health Services, and we also have CCALAC, which represents the community clinics in the county. So we're really lucky to have a partnership with a lot of folks at the table who are separately working on all sorts of different integration initiatives that are very exciting. So for our project, we're focused on this concept of health neighborhoods, building them up, supporting them. So it's a little bit different in terms of the needs assessment. We're lucky to have a great public health department and work from our departments of mental health and public health to map prevalence, some pretty good work on supply and demand that we already have. So our needs assessment is more along the lines of figuring out where those collaborations, integrations, at different levels, where are some interesting models happening in the county. Since we're big in LA, we kind of have 1,000 different flowers blooming, which can be fantastic. But one of the things we really hope to do with this project is figure out when there's successful integration or care coordination happening, in one location, how do we support that and build it, and can we come up with some kind of a blueprint and infrastructure to support that kind of collaboration. So some of the things, we'll be thinking about in the future will be things like, what data sharing needs are available, what level of integration is this collaboration at, and how can we help push them to the next level in terms of connecting with community providers like housing, social services, et cetera, or, furthering the integration itself. So our gap assessment, so we're about to start taking an inventory of programs and trying to figure out, what are all those different collaborations that are happening across the county. Some of that will be done just kind of by talking to our partners. We're lucky in that, because in addition to this project, all of the folks we're working with are also working directly with service providers. We have kind of an on-the-ground ear to what's happening, and then we'll also use some formal tools that are still in development. They're not ready yet. And so from that, we'll sort of say, okay, where are interesting things happening, and then map around what are the social supports community services or other clinical services that are available in those areas that might be ripe to become a stronger health neighborhood. One other thing that's going to happen later in the spring, so we don't have any tools of that kind yet, but we will be doing, once we've completed our inventory, we'll also be selecting 4 particular communities to work on and develop more tailored health neighborhood models there. So once we do that, that's where we're going to be wanting to do a community assessment and integration, and that may take the form of focus groups, community meetings, individual interviews with stakeholders. So that's still to be determined. Let's see, that's probably a good place to start, but I know we have Hugh from our behavioral health department on the phone at LA Care. We have Wayne from the Department of Public Health and Joanne from CCLAC. So if you want to add anything, please feel free to jump in.
I think I did, Allison. Thank you.
Oh, okay. Are there questions?
So this is Rachel. You mentioned the county having done some work on kind of supply or demand and supply issues, and also I know you mentioned some mapping that you all had done down there. It might be helpful for us to hear more about that work that you've already done, and if it could inform kind of what others are doing in those areas.
Sure. So I think, again, in terms of the prevalence data, that's really been done largely by our public health department in their more public health epidemiology hat, as opposed to the public health substance disorder service provider hat. Wayne, do you want to speak to that, or I can? I'm happy either way.
Okay, I can talk a little bit about it.
Sure, that'd be great.
As part of our regular health surveillance, we do conduct an annual LA health survey of county residents, and also we monitor various statistical indicators, and so those kinds of all that whole database is going to be available for our to help inform our planning process.
So, sorry, Apana, I think I lost my internet connection, so I just want to alert you to that.
Yeah, I thought you disappeared.
I've been having trouble with my internet today. I apologize for the technical difficulties on the call. So perhaps you can, I'm not sure if you can get us back a connection where we can see a desktop.
Yeah, I'm going to pass the presenter right to Carolina. She's going to bring up the PowerPoint.
Okay, great. Appreciate that. Okay, sorry for the distractions. So any other further comments or questions from the LA group? So we're still in developing the tool stage.
Yep.
You certainly have a large geography, so you're going to try to hone in on those. I wanted to ask you, when you said you're doing an inventory, is that going to be across the entire population spectrum then? Are you looking at mild, moderate, and seriously mentally ill, or what are your thoughts on that?
That's a good question. We thought to do it across the spectrum where the inventory was not so much focused on providers serving a particular population, but more on providers that already have some level of integration or coordination.
I see.
So that's, one way to narrow it down, and it does, does leave room in the future to talk about, well, what about the folks who aren't at any level of integration yet? What tools can we provide to them? This is more about finding folks who are already working together at some level. I guess if you're going to be formal about it, sort of the levels 2 through 6 more on the integration spectrum, or even 3 through 6, and figuring out how we can help them together better. So that's part of it. What infrastructure do they need to share information, coordinate care? But also, what are the ways that we can support them in interacting with community-based providers? Because even many of the collaboratives that are already integrating at the clinical level for physical and behavioral health may not have as strong connections with other kinds of services.
Okay, got it. Okay, thank you. Let's move on to Merced, and then we'll finish up with San Bernardino.
Kathleen Grassi. Sorry, I jumped on the call a few minutes late, so I didn't introduce myself earlier. And I know Jennifer and Karen are on the call, and Desert Vista is our consulting group for the gap analysis on this project. So I'll say a few words and then turn it over to Jennifer or Karen. We are just getting started, as many of you are. We had a kickoff meeting at the end of August. And as Joel mentioned, Joel's been a consultant for us on another project, actually funded through Blue Shield, as well as the California Endowment that's wrapping up. And as part of that, there was a high-level developed by Joel on behavioral health services in the community. So we have a high-level piece to start with in regards to kind of the thought of the Merced County community and services provided through our FQHCs, as well as through Beacon, which is the behavioral health service provider through the Alliance, Central California Alliance for Health, which is our Medi-Cal managed care organization. Our next big meeting is in October. We've been expanding our group, so we have a sort of a core group of clinic COs, the Alliance, and the hospital located in Merced, as well as the mental health department and the public health department that have been meeting actually over the last several years, and now we're trying to expand our membership for this project to include directly some behavioral health service providers, both at the clinics as well as in the community. And so that's happening. We've had a sort of a visioning discussion in August and again in September, and then the larger group will be coming together, as I said, in October to look at the gap analysis tool that Jennifer and Karen have developed. Additionally, we're contracting with 2 of our FQHCs to help us with the consumer survey and analysis, and that's was to be developed. My idea is to only capture individuals who are flowing through those 2 FQHC clinic service areas, but also our public health department is engaged with the Mental Health Services Act funding in our mental health department for chronic disease self-management program services. And if you're familiar with those are sessions that we offer on chronic disease self-management in the community. So these are not necessarily individuals that had any sort of diagnosis on the spectrum, but one of the sessions really gets into co-occurring depression with chronic disease diagnoses or conditions. And our interest there is to linking it back to mild to moderate services. So we're to bridge sort of the crime disease prevention work with health services as well. So we feel that this is going to be a good audience to include in our consumer issues as well. And then lastly, I'll say that the mental health department is very interested in making sure that the severely mentally ill population is also included. And I was interested in the earlier discussion about identification and participation among that group. So it is something that we intend to include in our work, and we'll be potentially consulting with those of you who are thinking as to how to include that population. Turn it over to Jennifer or Karen on the gap analysis development.
Hi, this is Karen Linkins, and as Kathleen laid out, I think that you get a sense that that the focus of the work in Merced is very much in the context of systems change, and that's one of the ultimate outcomes that they're seeing. It's really to transform
Oh, sorry if I'm not muted.
This dog is not in agreement with you, Karen.
Sorry.
Elmo.
That wasn't Elmo?
No.
Okay, so as I was saying, to really increase capacity in the county to provide integrated care in a bi-directional kind of way. Heard Kathleen talking about really the recognition that there is a need for flexibility within the system to address the full spectrum of need. And the focus of this collaborative right now is really, on that piece, which is, building capacity for integrated care, and then also to strengthen the collaboration across collaborative members. I think what is unique, and similar to some of the other projects, but what we've seen is unique with this collaborative is the public frame that is overarching this, because the lead grantee is actually public health. And so from the standpoint of the gaps analysis, the way that our starting place for the gap analysis and the endpoint for the gap analysis is very framed by this notion of transforming the system to have capacity for integrated care. So the analysis is very much at the organizational and sector level, cross-sector level, as opposed to the population, because we know that the secondary data sources that exist in the county to have a decent handle on the need, the prevalence data. You can use national estimates of prevalence and apply them to the county. That's not perfect, but it's definitely a starting place. And as Kathleen suggested too, their focus is definitely on behavioral health, but it's also looking at it in terms of complexity of the population, recognizing that there's an intersection of behavioral health and chronic illness. And so when you get into prevalence and incidence and prevalence estimates for that kind of population, it's a little trickier. So we will definitely, be looking at some of the secondary data sources that are available to paint that context. But our focus of the primary data collection for the gap analysis is really going to be at the organizational level. So we have, the idea is to take a pulse of where the clinics and where the other providers are in the county related to integration, and then also to get a better handle of the types of populations that they currently serve. So we're using the 4-quadrant model as a frame there. And then the other piece of it is using key informant interviews to identify what's that universe that we need to be surveying for, to define this continuum. And our estimation at this point, based on the goals that were laid out during the visioning exercise, is it will be traditional. There will be the traditional providers, the FQHCs, the community health clinics, the different behavioral health agencies and providers, as well as the hospitals, that sort of thing. But then including this collaborative are members who have a focus on, space health and a variety of other sectors that really need to be brought into this bigger picture. So the ultimate goal, another frame for this gap analysis that we're working to develop with Merced is to think about this in the context of the triple aim, where what I'm describing as the focus on the current capacity of the system to provide services and improving that's really the focus on improving quality within the system, and then the work around the collaborative and strengthening collaborative partner relationships and that sort of thing, and really moving toward collective accountability is an important component of everybody on the same page in terms of what improving population health looks like for the county.
And I wanted to add that, we've, as part of the gap analysis, when we were there in August in person, we facilitated a visioning exercise, as Kathleen mentioned, with their partners. And part of that was to understand, where's Merced as a community starting, and then what does collective accountability mean to them? So all of these different partners that were in the room talked about what collective accountability meant to them. And part of identifying the gap, the systems level gap for them, is that there needs to be more work in terms of outreach and engagement with law enforcement and the criminal justice sector. So, even, when we were just getting out of the gate with this grant, they're already thinking in terms of, in 12 months, what does change look like for them in Merced? And part of that was defining who are the people that need to be at the table in a more robust way that aren't here now. So that's sort of the lens that the Merced collaborative group is taking on defining systems change and looking at the gap, where the gaps are now and where they want to head next year.
And, we're right now, as Kathleen suggested, is that we will be working with the group late in October to refine a draft survey that we've put together that would be administered to the range of providers and entities kind of on the service side of things. And then prior to that, we actually will be beginning to work on our key informant interviews to additional information that Jennifer was just suggesting. And then the only other thing that I wanted to add is that a good data source that we're excited about that Merced has, and my hunch is that it's going to be available in some of the other counties, through the Alliance Health Plan. Dr. Bishop, the medical director, as far as I know, I think that he's doing this monthly, but he's been analyzing the increased demand or request for services, behavioral health services since January, since the expansion of the behavioral health benefit, and with that as a nice kind of indicator of demand. And what that means, it doesn't get at prevalence, but it is suggestive of incidence. So I haven't completely figured out how we'll be integrating that data in, but that's another data source.
Doing that, Karen?
That's the Alliance.
Oh, that's cool. That's good.
Mm-hmm. So good. I think, and I think that this is where that might be, I would imagine that Partnership Health Plan and certainly up here, I'm sure that that you guys, do these types of estimates too, but that might be a place for some standardization across these products to at least get that level of information from the health plans that are, that are basically addressing the mild to moderate.
Mm-hmm. And certainly an Empire in San Diego is actively looking at that data as well. The other I wanted to add about our process, and this is going to be similar across both Merced and San Bernardino, is we really are, based on sort of these early conversations that are so important that get the different collaborative partners on the same page around the vision, is to really develop a logic model for this grant so they know who all of the players are and what they're looking at in terms of their activities and how that maps on to their short-term and longer-term systems change goals.
So the process of developing that too, and we can make it available to everybody in the next couple of weeks.
That would be great.
Really helpful.
that would be great.
The whole, starting with the definitional issue around, collective accountability is an interesting way to go and really important, I think, because it's clear. I mean, we heard that from Doreen right out of the gate, right? That people have different definitions of how they're defining integration, even.
Well, just clarification on that. We, we definitely are using definitive integration from the literature and from, what we know is in clinical practice. But I think there's less known about what integration looks like at a systems level. So that's part of the goal. I mean, the gap analysis is really trying to, at least the way that we're operationalizing it, is really understand where integration exists in the county and what does it look like in any of these potential sectors, and all of that kind of stuff. I mean, along the lines of what was described in LA. And the other piece of it through this work is to really understand what does systems integration look like, and where does this group want to go?
And what are the roles? Because each collaborative, I mean, we're not just talking about, clinical, integration that goes on within a behavioral health or a provider or an SQHC. I mean, we've got health plans and hospitals and clinic consortia at the table. So it's really understanding what is their collective contribution and role to advancing integration and care coordination during this grant and beyond.
This is Kathleen. I just wanted to add two things. One, on the collective accountability, I think this is really very timely because not only are we as a community of providers addressing the changes that we're experiencing through the Affordable Care Act implementation, but we have here locally 3 key leadership changes happen this year. In our mental health department, in our major hospital CEO level, the mental health department director level, and our largest FQHC at the CEO level.
Wow.
So having those 3 key position players, and those were all players previously that were very committed to this collaborative effort, having leadership change happen we're in the middle of it, is just a dynamic that will be influencing our process. I think the discussions around this project and the collective accountability discussions in particular are really timely because of these leadership changes.
Wow.
And the other thing I wanted to mention just briefly, Karen was talking about Dr. Bishop's work at the Alliance in regards to looking at utilization in regards to the mild to moderate behavioral services through their membership. And at the same time, he's also tracking emergency department utilization. And while behavioral health utilization is close, the ED utilization is decreasing. And while, we know the particulars of why folks go to the ED or why they may not be going to the ED now, assuming they have, they're going to primary care instead, we also know that there's a lot of behavioral health connect at the ED level, the emergency department level. So I think that's an interesting thing to watch as well, if people are actually not showing up at the ED because they're able to access mild to moderate services before they get to a crisis point. And we have included, as one of our new members for this collaborative, the manager of the emergency department at our largest hospital. So we'll just, that'll be another, venue to watch what's happening in regards to this integration and these changes.
Wow. Well, an impressive story to tell. If we could tell that out of this. That would be great.
I just want to say, I know we're running a little behind in terms of what our hopes for the agenda, and so I want to use Carrie and Jennifer's comments about prevalence data to just underscore what we were going to talk about anyway, and we can breeze right past it, which is I appreciate sentiment and you talking about that prevalence data is not necessarily the most important thing that we're looking at in this gap analysis, but we really pass go until we have an estimate, and that we are happy and encouraging for anybody to use secondary sources and just extrapolate nationwide data. That is completely fine. our goal in wanting that prevalence data is really to go back to this collective accountability framework, thanks to Karen and Jennifer, of course, to really so that all the players at the table in the community have a collective idea about what the prevalence is, because our historical tendency is always to look at our own demand and need within our own organization. So that was really the goal, really, of having a general sense of prevalence data, however imperfect, and that there isn't a need to spend endless time gathering your own local prevalence if it's somehow burdensome. But to use those secondary sources just so that there's a collective agreement and understanding about the population's needs. So I appreciate you guys mentioning that.
Yeah. So time, I know we're running over, but I think it's really important for everybody to have the same understanding of what everybody's doing so that we can have a conversation a little bit about the couple pieces that are on our slides that we haven't talked a lot yet. So I don't want to cut off Merced, but perhaps Karen and Jennifer, you can segue us into San Bernardino with your colleagues. San Bernardino?
Sure, Liz or Mark?
Hi, this is Liz. So as Karen and Jennifer mentioned, our approach to the gap analysis is pretty similar to Merced. So I can leave any details to Karen and Jennifer if it's any different, but I can talk a little bit about who we're reaching out to, which agencies we've had involved as far as our gap analysis. So for our gap analysis, we're including all of our primary care clinic members under the association, and then we're also including the county behavioral health system and the county behavioral health system of public health, our local health plan, which is IHP, another organization called Association of Community-Based Organizations, which are mainly comprised of mental health and substance abuse providers. From these, we're doing a survey tool that's pretty similar to what we're doing with Merced, and then also we're going to be doing key informant interviews highlighting each of these agencies.
Just to jump in there, Liz, I think that what's important about what San Bernardino is doing, I mean, because all of this, obviously, healthcare is local, and so everything needs to be tailored to the unique needs of the counties in which these projects are occurring. I think that what's important to recognize with San Bernardino is that they have an existing collaborative that they've been working with for at least a year, and this collaborative includes members from primary care, from mental health and AOD, the health information exchange side of things. I mean, it's a pretty diverse collaborative. And so, again, part of the focus will be to look at the functioning of this collaborative, the relationships, and, really looking at the extent to which they're able to operationalize this broader and getting clear on what that vision is, because San Bernardino, because of the geography and because of the landscape, really the healthcare ecosystem that's so unique that it includes not only clinics but also independent providers, independent primary care providers. They have rural and urban issues. I mean, like many counties, but there's a complexity there that their partnership has been trying to address. So, part of the work that they are going to be doing in the next period of time, which is concurrent to what we're trying to do with gap analysis, is to really hone in on what that vision is and what, kind of getting that progression of what's doable in next year versus where they really want to be going. And have a very, a great champion in county mental health that I think is a very positive component of this. And then the other thing that I would say, because I see on the agenda that you wanted to know difficulties, we actually began to field the survey for San Bernardino because we were trying to get information to bring to a meeting that we had with them last week. And, we learned, which is not surprising, but the response rate is often challenging. And so I think that, for those of us who are, thinking about using the survey as a tool for data collection, we just have to be really mindful of what it means in terms of getting good response rates, the burden that happens when you go to clinics, and, eventually finding the right person to respond to the survey. And the other piece of it is, where it fits into a priority, because, we're working through a clinic consortium, and they have many asks to members, and this is one of them. They do other surveys and that kind of thing. So we have to put this into the context of the priorities, and, and try to not overburden the clinics in terms of this kind of data collection. So we're trying to be very measured about this.
And I think CPC at the state level is going through a concurrent data collection effort.
We shared that with everybody, yeah. Mm-hmm.
We have to be aware of, in the pecking order of priorities, when something comes across the inbox, FQHC, are there other ways that we can be gathering this information to advance beyond the survey? So we're looking at some creative ways for that as well.
Right. That's a really important point.
I wanted to mention in terms of San Bernardino's secondary data, they actually fielded an integration survey last summer. That's a really nice start place for us.
Where the membership is on their integration, their status of integrated care. So we'll be leveraging that as well.
So, in the interest of time, I'm going to suggest that if there's comments or questions that maybe we move into, I want Elizabeth to walk through what we have, because I think that listening to everybody, it sounds like, first of all, it's an amazing amount of energy and effort going into this, which is great and really exciting to hear. And I think, when I looked at the surveys that some of you are already using, there are some pieces in there, as I said, that I think can serve as building blocks for some of the areas that the Foundation's interested in. But maybe we should quickly go through the couple slides we have here, and then use the few minutes we have left to just get your reactions and thoughts about where, and back to Rachel's opening comments about where she's asking us to stretch a little bit, and how and if and is there an opportunity to do to have some alignment in those stretch areas, because it sounds like the prevalence in the data piece, is moving along. So Elizabeth, you want to show us those slides real quick? Caroline, maybe you can advance our. I lost the privilege of controlling the desktop when my internet connection dropped off. So.
Yeah, I'm ready.
Let's move to the slides that show the. So I think I'm going to defer to the wisdom of the group here, but I think we've talked a little bit about all of you are trying to get at some information around this. So I'm going to spend time on this.
Hey, Mary, this is Rachel. Can I just make a quick comment about this? I think it could be interesting going back to what Karen said about extrapolating from national data. I mean, I know people probably have Medi-Cal enrollment data at the county level, and I'm guessing most counties have some estimate of their remaining uninsured population, even if it's rough, and then to take sort of extrapolate from national onto those figures to just get that rough number.
Right. Okay, great. Any other comments, anybody around this then? With some rare exception, people are trying to get at the mild moderate SMI. It sounds like LA might be a little slightly different there. Next slide then, because I want to focus for just a couple minutes on these last two issues, and I'll let you say something, Elizabeth, here. Elizabeth? Hello? Okay, I'll say something then. Can you hear me?
Yeah, we can
hear you. Oh, okay. So the two areas that I think it would be helpful to just, I want to get people's reactions to. So one is how much information we're getting from the non-professional services in the community. And I heard it intermittently, and so I wanted to see if people, if this is too much. It sounds like some of you are getting this for sure. It's only LA is, but this is that's of high interest.
I heard myself get unmuted. I just wanted to tell you.
Okay, so I'm just trying to cover your comments on this for you, but jump in.
Of course, I mean, particularly, and you can see just from the things I've mentioned, even though NAMI's on here, the three that I mentioned as examples are all substance abuse interventions, community-based. But I think particularly substance abuse is very different in the way that there's been, 50 or 60 years of 12-step groups and about 15 years of Celebrate Recovery groups, which are church-based, and Life-Bring and Rational Recovery, a little newer, but now a decade or more old. That there's been really robust community or, organic community groups around substance abuse, non-professional treatment. So I think that's really of interest to us if we can kind of get it at that. And it would be very hard to get it, utilization and things like this and outcomes, but really what we're looking at is presence of these things. And that's pretty easy to find out. I know that when I talked to many of you, you felt like this would be fairly easy to get. And I think that for those of you who are doing focus groups and have consumers and patient liaisons involved, when we talk about obtaining preferences and perceptions of community members, would also be really interesting to find out what the perception of these community groups are. But if we can just get at the existence of these, just for example, communities, the communities that have 250 AA meetings a week versus communities that might have one or two that maybe aren't even independent, maybe are run by treatment centers or something. That's a different picture of a community in terms of what the resources are for people struggling with substance abuse. So it's of interest to us.
Why don't you go, Elizabeth, to the next slide, and then we can try and have a couple of comments before we close out. And
so this is what Rachel referred to as stretch goals. And the interest in this is we just that sort of principle that if we're mapping needs and services or needs, the gap between those things. And if there are services available, but if the community perception by, a group of people or a part of the community is that service is not for them, or that there's significant barriers, or that it's not culturally competent, or et cetera, and then the service essentially doesn't exist for that population. So we kind of wanted to get at that kind of piece of this, that it's not just about the existence of services, and of course the classic example of this would be there might be mental health services available, but if there's no penetration into the Latino community, or if the Latino community perceives it as very high stigma and not necessarily for them, then it's important to have a sense of that when we're looking at our gap analysis. So what we're really trying to get at here, and these are only examples. These bullets are really just examples of what we are thinking would be interesting to look at.
And I think more page.
And this is another example of perception of services that we certainly, even as community members ourselves, we might know of a particular service and we would never set foot there, and we would never send a family member there. We have really low confidence. And sometimes there's actually, particular ethnicities, particular ages, particular members of the community. There might be sort of a large agreement about levels of confidence in particular services or particular places, and that's really important too, because it impacts whether that's actually an available resource to the population.
One more, I think.
So the access and capacity, of course, these are just examples of ways to sort of get at this. And I think most of these you all have talked about, and some are. Some of them I think are in many ways are really obvious. I think the ones that have to do with perception, the reason it's grouped with this sort of subject that we're talking about, is, for example, if there are organizations or services where there's significant barriers to appointment, then really whether or not there's open appointment slots, for example, if there's significant barriers, then it may not be a resource in the sense that we would like to consider it or have it be a resource. And cultural competency is obviously an example of that too, that whether or not there's capacity at a particular organization, if their cultural competency is really low, and the perception of community members is that service isn't necessarily for them, then that would impact access and capacity. So just sort of a encouragement to get outside perhaps the most basic form of assessing capacity, meaning availability of services and appointments, and to also look at what are the barriers to access.
So I think that on that, I think we just had hoped to have more of a time for conversation and discussion about these now. So I'm really, really sorry that we don't, but I have some thoughts and suggestions I'll throw out. First, I also want to apologize, Karen and Jennifer, we had hoped to have more time for you to offer us more insights about, given that you've done a lot of work in systems change, how this conversation today and what you were hearing from the group might map onto some of the work you've done. So we won't have time for that. But a couple thoughts. First of all, I think that, Elizabeth and I can commit to follow up separately offline with everybody to get your reactions to some of the stretch areas that Rachel highlighted and that Elizabeth just talked about right there. But, and also to just see if there are ways within, where you are in your work now to focus on and include some of this, or if not, to know that too, so that we can just be aware and mindful of that. And have that follow-up separately offline since we don't have time today. And then also, she's going to be sending out an email, which you'll get later, where we're going to set aside some blocks of time in the first week of October to just be available to provide, just follow up with any of the grantees on any issues, and perhaps we can use some time then to talk individually with you about that. But any quick reactions to this? I know people are to drop off the call. Stop and pause and see if people have any comments or reactions.
Yeah, and Elizabeth, this is Jennifer. I do have a quick reaction, and we're happy to go into it in more detail with you offline. But I just think that there's a really important conversation that needs to be had between really interesting and really important questions of interest and the feasibility of getting and the methodological complexity getting at the information, and specifically around perceptions, because I think that, as external evaluators or even as FQHCs or health plans or clinic consortium, by definition, the way that you would outreach to people to talk to them about their perceptions would be based people that are known to your systems. And so by definition, it's kind of the paradox. If we're trying to understand the perceptions of some people in the community who may have not perceptions of what's available to them, then they're going to be the hardest people to actually reach out to and bring in for either a focus group or try to get, a phone interview or that sort of thing. So yes, those types of activities for data collection have to be initiated by somebody, and they're going to be initiated by someone who's probably part of a system of care or a health plan or a consortium or whatever, and getting at folks who already know that you're there or may not really appreciate your services that you have available aren't going to be as responsive. We end up in kind of a paradoxical situation methodologically.
Right, it's definitely.
I hear that.
So I think that to really try to get at this information, we need to talk through the feasibility and strategies. And I think, a shortcut, especially in a grant of this length, would be to at least start asking those provider groups, do you in fact talk to your people about their perceptions of care, beyond your annual satisfaction survey? Yeah. So it might be that may be the precursor of to go to the system level and say, are you doing any of this outreach with your consumers and patients beyond, annual satisfaction and start there. And if they don't, then maybe start planting the seeds about a strategy about how they might go about doing that moving forward.
Right. That's a great thought.
It's a great thought.
Mm-hmm.
This is Ridley. I just have a quick question on the first point. I think Rachel was making about some national extrapolation of prevalence data using Medi-Cal enrollment numbers and remaining uninsured. If there's interest in kind of looking at this across projects, would it be possible for you all to set out some national prevalence rates that you would like us to apply to those numbers, that we're using similar estimates?
Mm-hmm. Yeah, look about that, Melanie.
Yeah,
I don't see why we couldn't do that.
Yeah.
Right? Work on that.
Yeah, for sure.
Yeah, definitely. I mean, I heard they just released a bunch of new numbers on some of that stuff, so I can work on it and get that to you. So I really apologize. We, just don't have enough time to have the kind of robust conversation that we'd like to have, and technology has not been our best friend today on this. But, I just want to, Rachel, if you're still there with us, offer an opportunity for you to just say any closing remarks. And then, as I mentioned, Elizabeth and I will follow up with everybody offline to kind of pull all these threads together and then, continue to have the conversation.
I'll just thank everyone for your participation today and for sharing what you're doing and just the amazing work that you're all, focusing on the ground. I guess to the point, respond to some of the comments about what's possible, the amount of time that, the grants are 12 months. I really don't want to see that as a big driver of kind of what we do. And so I guess my point is I would rather everyone try to get this right and we open up our thinking about timelines and funding and all of that, and I have flexibility on my end to do that. I think part of what I want to show back to our, leadership here is just the kinds of progress we're making along the way, and that can set us up to how we need to structure things in the future. So I don't want time or money to feel like a constraint to doing this right, and we'll grant anyone the flexibility within reason, to do the work in the way that that we want to do it. So thank you both to Mary and Elizabeth, to everybody on the call, and to our team here, Apana and Carolina, for being with us. And I'm just looking forward to next steps.
So that's really helpful, Rachel. Thank you for that send-off, and thank you to Apana and Carolina for your help. And so Elizabeth and I will follow up with you, and specifically around that last point that Rachel made about, not letting the timeline be something that sticks in the way of getting this as meaningful as we can possibly make it with you all. So I'll just add my thanks as well to everybody, and we'll be back in touch shortly and say goodbye and thank you.